morning, everyone, and good afternoon for those in Africa. My name is Dr. Onyedikachi Adike, and I'm a resident doctor of radiology in Nigeria. And I want to welcome all of us to today's episode of our weekly grand round for the Health for the World team. So we're privileged to have in our midst an erudite scholar who will be taking on the topic updates on pulmonary embolism. And her name is Dr. Kimberly Kallianos. Dr. Kimberly received her medical degree at Harvard Medical School in Boston, Massachusetts. And following that, she completed a one-year internship at Mount Auburn Hospital in Cambridge, Massachusetts. Also, she did her radiology, a four-year diagnostic radiology residency and cardiac and pulmonary imaging fellowship at University of California, San Francisco. Currently, she is an associate professor of clinical radiology at the University of California, San Francisco. Also, she is a modality director of CT and the director of cardiac and pulmonary imaging fellowship program. Thank you very much, Dr. Kimberly, for coming to join us today. And I wish you can talk to us. Thank you.
Thank you so much for that kind introduction. It's very nice to speak with you all today. I'll just go ahead and jump into the presentation. And if there are questions, I welcome them via the chat. We may be interrupted at the end, and so I can also answer questions via email if we don't have time at the end of this session. So with that being said, let me go ahead and share my screen and we'll begin. Okay, so the title of this talk is Update on Pulmonary Embolism. And so no relevant disclosures. Pulmonary embolism is a really important topic, clearly, in radiology, and a large PE such as this one is not usually a diagnostic dilemma. The patient is quite symptomatic in many cases, the imaging appearance is very clear, and so we can all feel confident about what to do in this case. That's in contrast to a situation like this to draw your attention to this small pulmonary embolism. Is this a real finding? Is this an artifact? Should the patient be treated for this finding? More of a challenging situation. So pulmonary embolism is both fundamental and controversial. It's an everyday diagnosis that we see if we practice medicine in an emergency type of setting. But it's also a diagnosis that's fraught with uncertainty and controversy. So what am I going to talk about today? I'll talk about the fundamentals, how to distinguish pulmonary emboli from common artifacts so that we aren't fooled and we can make an accurate diagnosis. And then I'll talk about some controversies, some special patient populations, as well as how to proceed when the diagnosis of pulmonary embolism is uncertain. And then I'll follow up with some other emboli that aren't thrombotic pulmonary embolism, but that fit under this umbrella topic. And my message will be that focusing on the fundamentals and keeping up to date with the controversies will help increase our comfort with the diagnosis of pulmonary embolism. Okay, so fundamentals, what are we looking for? Right? The general rules that I follow when I'm diagnosing a pulmonary embolism on CT is that the finding or the filling defect must be on multiple contiguous slices. One slice finding is not enough. Right? It must not be in an area of motion. If there's very severe motion, often what you're seeing is an artifact. It must be the density of thrombus, and I'll talk about that in just a few slides. Okay, so here are some examples of the findings of acute PE. You can see central filling defects with a rim of contrast in this patient with quite a high burden of pulmonary emboli. Occluded vessels can often be more difficult to detect because you don't have that rim of contrast going around, just an abrupt cutoff. And you can see small portions of thrombus straddling a bifurcation or broken off and caught at a carina of a vessel. Now, what do I mean by the density of thrombus? So a study in radiology looked at acute and chronic PE, and after going through a series of cases, came to the conclusion that acute PE should be less than 100 Hounsfield unit. And the mean attenuation of acute PE was actually 33 HU. So chronic PE in their setting was 87 HU as the mean. So when you look at the bell curve and the distribution, acute PE should really be less than 100. If you're putting a region of interest on something you think might be a pulmonary embolism and you're getting a very high density, like 300 or 400 HU, that is extremely suspicious for contrast mixing, and you should not diagnose a PE in that setting. I just alluded to chronic PE. What are the findings of chronic PE? They're illustrated on the slide here. Eccentric defects along the edge of the vessel with an obtuse angle to the vessel lumen, a vessel wall thickening, as well as abrupt caliber change in a vessel. So you can see here, these are two contiguous slices, and there's rapid tapering of this pulmonary artery branch supplying the left lung. Other findings of chronic PE, eccentric, as I mentioned, calcification within a pulmonary artery. You really shouldn't have pulmonary artery calcification. And so it's not a place where we commonly have atherosclerosis, for example. So a filling defect with calcification suggests chronicity. And then webs, these thin band-like defects that go across the center of the vessel, another sign of chronic pulmonary embolism. What about lung parenchymal findings that we see in patients with pulmonary embolism? Mosaic attenuation, which is different density of regions of lung, is also associated with pulmonary embolism, specifically chronic thromboembolic disease. And it's larger regions of mosaic attenuation or mosaic perfusion that are most suggestive of chronic pulmonary embolism. You'll see higher density lung centrally and lower density lung in the periphery, indicating the portions of lung that have decreased pulmonary arterial blood supply as a result of chronic thrombus. That's in contrast to mosaic attenuation from airways disease, right? So it's different regions of lung density, but very different in terms of the distribution. Airways disease will be smaller, lobular regions of lower density corresponding to air trapping, and expiratory imaging will accentuate the difference, emphasizing that air trapping is the underlying pathology. Some correlated signs you may see outside of the pulmonary arteries and the lung parenchyma include evidence of elevated right heart pressures. A right ventricular to left ventricular ratio greater than 1 is an important finding to notice because this is a very poor prognostic factor. You may also see septal bowing, a reflux of contrast into the inferior and superior vena cava, dilated superior vena cava and azygous veins, but those are less helpful signs prognostically. Clot burden, meaning the absolute volume of clot, and whether or not there is central versus peripheral clot are important to note in our report, but it's less helpful for predicting whether or not the patient will actually develop elevated right heart pressures. And so taking a look at the chamber size directly is the best proxy for that we see on CT. And then patients clearly go on to echo and other cardiac assessments. Strain is a terminology that some people use to describe elevated right heart pressures on CT. I don't recommend using that as a CT term because that term has a specific meaning to our colleagues in echocardiography. What are some complications you may see in the lung parenchyma in a patient with pulmonary embolism? Pulmonary infarct occurs particularly in patients with peripheral pulmonary emboli, and what you see is ground glass opacity and consolidation downstream of an occlusive pulmonary embolism. Here's a dual energy CT nicely illustrating the absence of flow in this area of ground glass and consolidation on an iodine map, emphasizing that it is in fact an infarct that's developed. Another example of infarct, peripheral, ground glass, and consolidation. One specific morphology you may see is something called the atoll sign, where you have a peripheral rim of consolidation with central either normal lung or ground glass opacity. That sign is not only seen in infarct, but in this setting of pulmonary emboli, the atoll sign is consistent with an infarct. And again, as I mentioned, infarct more common with distal pulmonary emboli. And if you think about the dual blood supply of the lung, pulmonary artery, and bronchial artery, when you cut off the pulmonary artery flow, that's what's going to happen and be more likely to cause an infarct peripherally. So I talked about the common normal findings, or common classic findings is a better word for that, of pulmonary embolism that make us think of this diagnosis. What are the artifacts that might fool us? Motion, this is a huge one. Contrast problems like mixing or streak artifact, mimics of pulmonary arteries like airways or pulmonary veins, and then finally some image processing artifacts. So I'll go through each of these in turn. So motion is going to be your biggest problem when accurately making a diagnosis of pulmonary embolism. This is sometimes also called ghosting. And you can see in this example that on the left panel there on the mediastinal windows, or that there's a contrast in a vessel and then a more hypodense portion peripherally. Could that represent a pulmonary embolism? It's a little bit strange given its position off to the side. That should make us suspicious. And then when we look at the lung window, we can actually see that there's quite a bit of respiratory motion, and this vessel is blurred out and superimposed upon itself twice. And that's what is giving the appearance of a pulmonary embolism when actually none is present. So this is an artifact. Pulmonary embolism should not be called in this case. Contrast timing also matters. This is two examples of problems with contrast timing. Here on the left of the slide, you can see very dense contrast in the superior vena cava and the pulmonary artery, with almost none in the aorta. And then on this curve reformation going out the pulmonary artery tree, you can see that the contrast starts to dilute or run out. This is an example of very early timing, and we just haven't given enough time for the contrast to flow to the distal pulmonary artery, so too early. That's in contrast to this other example. This is a patient who'd also had a coronary artery bypass surgery. You can see relatively dense contrast in the aorta, but the SVC and the pulmonary artery are washed out. This is too late. So it will be difficult to adequately exclude a pulmonary embolism, especially in distal vessels that are poorly opacified. I want to make a special note of a phenomenon called transient interruption of contrast. So this is a situation where if you look at the left panel, you have features that look a little bit like it's too early and a little bit like it's too late, and it can be confusing the first time you see this. And what do I mean by it's both too early and too late? Well, you can see that there's dense contrast in the superior vena cava. That would imply, oh, perhaps this is too early. But there's also very dense contrast in the aorta. That might imply that we're obtaining our imaging too late, and the pulmonary artery is washed out. So what's actually going on here? As I mentioned, this is something called transient interruption of contrast, and what's actually happening is you have flow of unopacified blood coming up from the inferior vena cava. You can see that on the coronal image, and it washes out the entire right side of the heart, the RA, the RV, and the pulmonary artery. Why is this flow happening? This is what happens when the patient valsalvas during the breath hold of their scan. So if the scanner tells your patient to breathe in and take a breath, they bear down hard, increase their intra-abdominal pressure, and all of this unopacified blood rushes up and washes out the pulmonary artery tree. So if we notice this artifact and we need to repeat the scan, it's very important to counsel the patient and to tell them, don't bear down or strain when you hold your breath. But recognizing the artifact is important to give that instruction. Okay, another contrast-related artifact that we sometimes see is contrast mixing. I alluded to this when I was talking about Hounsfield units and putting a region of interest on a possible filling defect. If you happen to have a very fast scanner or you happen to have poor cardiac function, you can outrun the bolus or scan the patient before the contrast has mixed in the pulmonary artery. Slow flow related to other intrinsic patient factors like lung disease can also mimic thrombus. So you can see in this patient with interstitial lung disease, there's slow flow to that area of dense fibrosis. That's physiologically appropriate. The body is sending less flow to this damaged lung, but that results in this mixing, and it can fool us or mimic a pulmonary embolism. So again, if you put a region of interest over this portion of the pulmonary artery, you would very likely obtain a high number greater than 100, and that would make you more confident that you're dealing with mixing of contrast. Another situation where you have mixing is bronchial artery inflow. So there are anastomoses between the bronchial arteries and the pulmonary artery tree. These bronchial arteries can become hypertrophied in patients with chronic infection, congenital heart disease, chronic thromboembolic disease. And if these vessels are larger, they can dump a larger amount of blood into the pulmonary artery tree. Now, in this particular case, there's actually denser contrast in the aorta and in the bronchial arteries. So that's not going to mimic a PE, but you can imagine at a different phase of the cardiac cycle, less opacified blood dumping into the pulmonary artery via this bronchial artery anastomosis. Streak artifact, usually this doesn't fool us too badly. We can see that there is dense contrast, for example, in the superior vena cava, like in this patient. We can see that the patient's being scanned with their arms at their side, or that there's spinal fusion hardware, ballistic fragments, whatever it is inside the body that causes these dark bands that go across the pulmonary artery branches. That is not a pulmonary embolism, it is an artifact. What about other structures that mimic PE? This patient has extensive mucus plugging, and these are mucus-filled bronchi rather than occluded pulmonary arteries. But at a quick glance, you want to make sure you're looking at the correct structure when you see a filling defect. Similarly, with pulmonary veins, you can have contrast mixing or pulmonary venous streaming in pulmonary vein branches, depending on how contrast is flowing through the body. It really looks like a PE, but when you trace backward, you realize it's simply mixing of contrast in a pulmonary vein. So that's not anything to be concerned about. And then finally, depending on the type of image processing that you're doing, there are edge enhancing or sharpening algorithms that can be applied to our CT images to, for example, improve our assessment of the lung parenchyma, but these can cause some artifacts that, for example, accentuate the density of the periphery of vessels and make the central portion look more hypodense. Is that a PE, you might wonder? But if you put on a soft tissue kernel, that effect is gone. So just thinking about how your images are being processed at your institution could be mimicking a PE depending on the case. All right, so I've talked about the appearance of pulmonary embolism. I've talked about artifacts that can fool us. Now I want to take some time to talk about controversies, special patient populations, special situations to increase our confidence in this scenario. And I want to start with pulmonary embolism in pregnancy. So this is a significant source of pregnancy-related mortality, highest risk in the postpartum period. And unfortunately, there's an overlap with normal pregnancy symptoms in terms of dyspnea and the symptoms of pulmonary embolism. Fortunately, PE is quite rare and diagnosed in less than 10% of pregnant patients coming into care with dyspnea, but it is important to think about. And D-dimer is unfortunately not very useful in pregnant patients given the multi-system activation that's going on within the body. So this is a paper from the American Thoracic Society that's about 10 years old, suggesting a way to evaluate a pregnant patient presenting with suspected pulmonary embolism. And so the point of this algorithm is to try to use the lowest radiation dose tests first before escalating patients to a high radiation dose. And so in this algorithm, first we're screening the patient for symptoms of DVT and if possible using ultrasound to diagnose them. If DVT symptoms aren't present, they're recommending a chest x-ray as an initial imaging test to look for example, pneumonia, pleural effusion, some explanation for their symptoms. And then this paper is using a chest x-ray to stratify a patient between VQ scan and CT, thinking that if the chest x-ray is completely normal, you could go to VQ or even Q alone, and I'll talk about that in a moment. And if the chest x-ray is abnormal and you need to figure out what's going on in this patient, then they send the patient down the PE-CT pathway. So that's one suggestion for how to use your resources in a pregnant patient, assuming you have access to all of these different modalities. Let's talk a little bit about the maternal fetal radiation trade-off, because that's what we're thinking about when we're considering the use of chest x-ray, VQ scan, or pulmonary embolism CT in a pregnant patient. So you can see here in the chart, the maternal radiation dose is going to be substantially higher with pulmonary embolism CT, and that's in millisievert. The fetal dose is actually quite similar between VQ scan and pulmonary embolism CT, depending on the technique, the type of scanner, and what you have available to you at your institution. So it's really less of a problem for the fetus. Both are going to be relatively low doses and an increased dose to the maternal tissues if you perform CT. So what about fetal effects of radiation? I could give an entire talk on radiation safety, but I just want to hit on some of the highlights as a reminder. We're not worried about teratogenesis until we're talking about 50 milligray. The childhood cancer risk, specifically leukemia, is increased following radiation exposure in the fetal or childhood period, but the absolute numbers are low. So it goes from a background rate of 3 in 1,000 to about 6 in 1,000 at 50 milligray. But we can be really reassured that the combination of doing a chest x-ray, a VQ scan, a PECT, and a conventional angiography of the pulmonary arteries exposes the fetus to a very low dose of about 1.5 milligray. That's because the fetus is not in the imaged area and the maternal body is, in a sense, protecting the fetus from the radiation. So you should not be concerned about teratogenesis, for example, if you're performing a PECT, and even this risk of childhood cancer is a small effect. What about the maternal effects? Well, it's the maternal tissues that are assuming the greater risk, the breast dose specifically, breast tissues being quite sensitive in pregnancy. There are some dose reduction techniques that you may use at your institution. For example, reduced KVP, reduced Z-axis coverage to keep the fetal tissues out of the beam, organ-based tube current modulation, depending on your scanner, and then just metal or lead abdominal shielding. That can be helpful, although you want to be careful. For example, in this case, the shield came into the imaged area. It caused a lot of artifact, which ultimately made the study non-diagnostic. And if you do have automatic tube current modulation, the presence of the shield in the imaged area will cause the scanner to increase the radiation output of the machine. So something to think about. So in the end, it's not conclusive what the best test is to do if you were doing imaging for exclusion of pulmonary embolism in pregnancy. There's some guidelines that essentially say, given the lack of evidence, it's really going to be institutionally based on what type of imaging modalities are available at your institution, the patient preference, the physician preference, and then logistical concerns at your institution. Do you have access to CT or VQ overnight, for example, that come into play when determining which test is performed? At our institution, we do pulmonary embolism CT preferentially, but I think there's an argument to be made for many different approaches in this setting. So rather than telling you all what is the best thing to do, I hope I've armed you with some information that you can use to decide what is the best and most feasible practice for your institution. The next controversy I want to talk about is isolated subsegmental PE, meaning isolated very small pulmonary emboli. Incidental small pulmonary emboli are relatively common, particularly if you're caring for hospitalized patients or cancer patients. And so the benefits of treatment in these cases is also unclear. There are complications of anticoagulation, and rarely are very small pulmonary emboli causing significant hemodynamic compromise, for example. So I just want to show some historical data from the internal medicine literature from about 10 years ago. This is in the United States, and you can see the incidence of pulmonary embolism as any diagnosis, the primary diagnosis, and the mortality from pulmonary embolism. And then you see here, time point 1998, when multi-detector CT PE was introduced. And as you can imagine, when you introduce a better scanner, the diagnosis of pulmonary emboli will increase, which is what happened in the study period. So the diagnosis of PE increased as our scanner technology or access to improved scanner technology improved. What about complications of anticoagulation? Do those increase once we're diagnosing more PE? And you can see here gastrointestinal hemorrhage, thrombocytopenia, and intracranial hemorrhage. And yes, right, those all increase as well. And I just want to take you back to the prior slide, just looking across the bottom here, mortality due to pulmonary embolism is static over this study period. So we're diagnosing more PEs and we're getting more bleeding complications, but we're not actually affecting mortality due to pulmonary embolism, likely because we're diagnosing these small emboli that are not likely to cause hemodynamic effects. Another important factor to think about is that disagreement about the presence of pulmonary embolism is also common. In one study of an AJR in 2015, the discordance rate for pulmonary emboli being present or not present was about 25%, even among experienced readers. And there was more frequent discordance in cases where there was only one pulmonary embolism or the pulmonary emboli were very small, like segmental or subsegmental. And so they looked at the cause of this discordance or disagreements amongst readers. And you can see here that the biggest problem was motion, respiratory motion, breathing, which I talked about a few slides back. It's really a problem, as well as beam hardening artifacts. So you can do something maybe about beam hardening if you have the patient's arms, for example, outside of the field. Hard to do anything about implanted hardware and breathing artifacts. These patients are symptomatic, they're short of breath, and so respiratory motion is also difficult to eliminate. What if we're very confident that there is a small pulmonary embolism? What do we do about that? Should these very small pulmonary emboli be treated, and does it improve patient outcomes? You can see here a series of 5 different studies that compared treatment versus no treatment for small pulmonary emboli. And you can see really no difference between the anticoagulation group and the no treatment group in terms of recurrent PE or fatal PE, although there was an increased incidence of bleeding or major bleeding complications in the group that received anticoagulation. Again, it's not conclusive about what is best to do. Should we withhold anticoagulation for small PEs, especially in folks with good cardiopulmonary reserve who don't have thrombus elsewhere within the body, for example, in the lower extremities or along a catheter? There's a prospective observational study being done at the Ottawa Hospital Research Institute that completed its recruitment in 2021, looking at whether or not it's prudent to withhold anticoagulation in patients with small pulmonary emboli and the absence of DVT, but we don't yet have the results of this study, so stay tuned. Ultimately, this decision is going to be made in concert with multiple providers, including those caring for the patient's clinically, medicine, or emergency medicine team. But it is important to be very confident in your diagnosis of pulmonary embolism, as we talked about the complications that might arise if these are treated, and very small PEs. Be confident, don't overcall motion. Okay. So what do you do if you're unsure that there's a pulmonary embolism? It may be artifact, it may be real. Here are just some tips from my own personal practice. You can ask your technologist to obtain a delay. That would be required, practicing in a setting where you have real-time access to the technologist, you're reading the studies in real time. If they're on a work list that you get to several hours later, this isn't going to help. But here's an example of a patient with a large mass and strange appearance of flow in the pulmonary arteries. Call the tech, hey, I'm worried this might be PE, might be mixing, can you do a delay? They scan the patient again. That effect is gone. That was a streaming kind of laminar flow artifact from compression of the pulmonary artery. What about if you think there's a tiny PE? What else can you do? Look for another one. I look really, really hard to try to find more than one thrombus if I'm not sure about a tiny defect. If you find multiple defects, that may increase your confidence. What about repeating the study? We certainly can do that. Especially if the artifact is fixable, like some problem with the bolus or transient interruption of contrast, we do need to counsel the patient about transient interruption and tell them not to Valsalva or bear down. And then there's some artifacts that aren't necessarily fixable. If the patient is extremely dyspneic and breathing rapidly throughout the study, repeating it may not yield a different result. And then at our institution, sometimes folks will have a pulmonary embolism CT of the chest and then an abdomen and pelvis CT done for a different indication. If you do happen to scan the patient twice, that abdomen CT is a second chance to look at the lung parenchyma. The timing is usually a bit later. Portal venous timing is essentially like an automatic delay of the lung bases and a second attempt at a breath hold, which can be really helpful. And then I'll just take the last few minutes here to talk about non-thrombotic pulmonary emboli before I move on to some time for questions. Pulmonary artery sarcoma is lurking in the back of my mind when I see a patient with a very large pulmonary artery filling defect. A pulmonary artery sarcoma is a central defect. It's often expansile, very large, and well compensated. So one of my mentors told me these are patients who have the biggest pulmonary embolism, in quotes, that you've ever seen, but they're not very symptomatic, right? If that was an acute thrombotic embolism, this patient would have no outflow of their heart, be extremely symptomatic. But if it develops slowly, like the way pulmonary artery sarcoma does, the patient tends to have more minor symptoms. So biggest PE you've ever seen, but the patient feels well, think about a pulmonary artery sarcoma. What about fat emboli? These are microscopic fat emboli. They cause endothelial and alveolar damage. And we don't actually see macroscopic fat in the pulmonary arteries, but rather see the effect of this vascular damage, ground glass opacity, septal thickening and consolidation, basically fluid leak. And it tends to peak 3 days after the long bone fracture or significant fracture. So on day 1, unlikely to see this effect. Amniotic fluid embolism, again, this is not going to be a CT finding in terms of seeing a filling defect in the pulmonary arteries, but rather the effect of microscopic amniotic fluid emboli. You'll see abrupt cardiopulmonary collapse in an intrapartum patient or immediately peripartum patient. The maternal mortality is quite high in the setting, and the CT findings are those of pulmonary edema. Air emboli does have a CT correlate. Small amounts of air related to contrast injection, particularly on the right side of the heart, are often asymptomatic, but we really worry when there's an intracardiac or extracardiac shunt that allows air to get over to the left side of the heart. There's actually an air blood level here in the tip of the left ventricle in this patient. So air in the left heart, potentially fatal. What about exogenous materials that can embolize within the body? We see cement emboli not uncommonly in patients who have had cement augmentation of their spine for compression fractures. You see here the cement embolize into multiple branches of the pulmonary artery tree. Oops, excuse me. Small volume of cement emboli doesn't usually require any treatment, but if there's a large burden, sometimes our surgeons will give anticoagulation, not to reabsorb the cement, obviously that's going to have no effect, but rather to prevent thrombus from forming on the embolized cement material. And then finally, we see patients who are treated for prostate cancer with radiation brachytherapy seeds. Here's an example of a brachytherapy seed that eroded into one of the veins in the pelvis and ultimately returned to the heart and was embolized into the lung parenchyma. So when you see embolized materials in the lungs, recall that these could really come from anywhere in the body that has venous flow or venous return to the right heart. All right. So my message here has been focusing on the fundamentals, and keeping up to date with controversies can increase our confidence in the diagnosis of pulmonary embolism. And I hope after this discussion, we all feel more confident in accurately making the diagnosis, as well as how to handle some challenging situations, for example, pulmonary embolism in pregnancy, and what to do with very tiny pulmonary emboli. Thank you for your attention.
Thank you very much, Dr. Kallianos, for this wonderful lecture, and it was quite educating, and I'm really grateful for your time. So I don't know, there's just a question on the chat box. I don't know if I should go ahead and read it.
Sure.
Okay, so it's from Dr. Enrique. So he said, do you use contrast in all cases?
Yes. So with CT, it's going to be very difficult to exclude pulmonary embolism without intravenous contrast. Those secondary signs, like example, pulmonary infarct, are present in the minority of cases. If you do have a patient who is not a good candidate for intravenous contrast, there are a couple of things you can do. We give contrast to folks whose GFR is greater than 30, really without any concern. So at intermediate levels of renal impairment don't stop us from giving intravenous contrast, and we have good success with that technique. We pre-medicate patients who are allergic to contrast using steroids and antihistamines, depending on the level of the severity of the reaction, so that we can still provide contrast even for folks who are allergic. There is a literature on doing MRI for pulmonary embolism. That's possible without contrast or with, but it's not done commonly at our institution, just dealing with access issues to MRI, the duration of the scan, and often the concern is quite acute, and we want the fastest imaging test.
Okay, thank you very much, Dr. Kallianos. Okay, I think there is another question. If you do not have automatic pump injector, can you use handheld syringe?
Yes, that's possible. The timing will be more of a challenge. So I think this happens sometimes, for example, when we have pediatric patients or very small patients, we don't feel comfortable using the power injector. So I would say if you are doing a hand injection, you're probably going to have more of a delayed phase by the time you inject the contrast, leave the room, and then scan the patient, but that's actually okay. Right? If you think about the pulmonary emboli that are going to be clinically significant, it's going to be the central and lobar, maybe segmental branches. So I would say that a more delayed phase that's a result of doing a hand injection is still adequate to exclude clinically significant pulmonary emboli. You do need to have experience in your institution with doing a hand injection, making sure you're doing that safely, illuminating air from the tubing, and making sure that the line that you're injecting in is safe for hand injection. You don't want to, for example, hand inject into a fragile line that breaks the catheter due to the pressure and causes a catheter embolization. And we've seen that happen as well. So you do need to have experience with that technique.
Okay, thank you. Can we take one more question? Or...
Yes.
Okay. So the question is, what about MRI in relation to patients with clearance inferior to 15? Or what about MRI without contrast?
Okay, let's see. What about MRI without contrast? Okay, yes. So we you can do MRI without contrast, like a bright blood sequence. It's going to show you the central and lobar pulmonary arteries, even segmental, possibly, especially if your patient is still and is able to cooperate with the breath holds. And someone who's very dyspneic and rapidly breathing, you're really not going to have success with that technique. I would say one other option is to use alternative contrast agents. One of those is something called faramoxetol or Faraheme. That's an intravenous iron preparation that is actually used for treatment of iron deficiency anemia in patients with chronic renal insufficiency. So it's given to people on dialysis to treat renal insufficiency. And that intravenous iron actually is an excellent blood pool contrast agent. So you administer it to the patient in the holding area. It stays in the vasculature for 12 hours or more, put the patient on the MRI scanner, and then you can do MRAs at multiple different attempts at an MRA. And that gives you a nice look at the pulmonary arteries, all arteries actually, because it's a blood pool agent. So arteries and veins are all opacified, but that's another option.
Okay. Thank you very much. I don't know how many more questions can we take. So because we have 3 here, should we take maybe just one? Maybe the rest can come to your email or?
Sure.
Okay. So this question is, in what time? Oh, okay. The first question is, in what time period after cement embolization are the anticoagulants given for prevention of PE?
Usually it's acute, like within the first 3 months after the procedure, and that's only in patients with a large burden of cement emboli. That's going to be the surgeon's preference.
Okay, okay, okay.
I can probably answer the rest of these other two. Go ahead.
Okay, so how can you differentiate infection versus those atypical PE for which we see only secondary effects?
Yeah, it's definitely happened to me that I've read a non-contrast CT. I see a region of peripheral consolidation, and I wonder, is this just a bacterial pneumonia or is this a pulmonary infarct? I wish I had like every time this is my trick to answer it, but sometimes it's not clear. You can do, DVT ultrasound to look for a clot somewhere else in the body. But sometimes I'll say this is either a peripheral pneumonia or a pulmonary infarct, correlate with the patient's symptoms or risk factors for PE. And sometimes I will recommend that they actually do a contrast enhanced CT of the patient to exclude pulmonary embolism. But you're already part of the way to success by just even thinking of the fact that it might be an infarct and not just a pneumonia. If you don't think of it, you won't make the diagnosis.
Okay, thank you very much. This one is, can you do PECT in any trimester in pregnancy?
Yes, you can. Again, the effects, the radiation to the abdomen is very low with an appropriately performed CT of the chest. And so if the concern is high, we would go ahead and perform CT regardless of the trimester.
Okay, thank you. And the last question is, what's the role of nuclear medicine? I don't know, it's from Enrique.
Yeah, so I don't myself perform, I'm not a nuclear medicine physician. VQ scan, I talked a little bit about the data in terms of the radiation dose. I think VQ has a particularly important role actually in chronic pulmonary embolism as opposed to acute pulmonary embolism. But I think that's going to really depend on your institution and your availability of these different modalities. One option, right, is to do a Q only scan, so no ventilation, just perfusion. That's a possibility that lowers the dose to the patient as well. But I would say now we're outside my area of expertise in terms of the strengths of a VQ scan for acute PE and the PIOPED criteria. So maybe you'll have a nuclear medicine physician come and give a talk.
Okay, thank you very much, Dr. Kallianos, for your time and for the wonderful lecture. We're really grateful from all of us at Health for the World. We say thank you. And then we hope that you oblige us your presence when next we call.
Of course. It was so nice speaking to you all, and I hope you all have a wonderful day or night.
Thank you. Okay, so to all of us, thanks so much for your active participation. Just briefly, I just want to share the website on the chat box so that we can go through what we do at Health for the World and can check the whole services we render, and then you can follow us on all the social media platforms. This webinar is held every Friday, 7 p.m. Pacific time, 7 a.m. Pacific time, and then 10 a.m. California time, 10 a.m. and also 3 p.m. London time or West African time. So you can follow us on all our social media platforms, and I'll post them on the chat box. Thank you very much for your active participation. See you next Friday.